Good morning. I'm Danek. I'm an RT in interventional neurology, and this morning we are going to go over the features and preparation of a Terumo Pinnacle 7 front sheath. We're going to learn the features of the device, which are fairly uniform no matter the make or model of the sheath. It's a simple intravascular access device. It's pretty standard across the board. We'll go over why and how it's used. And lastly, I'm going to show you the proper way to prepare it for use. Traditionally, this is done under a sterile setting, so we have our simulated sterile field. Vascular access, it's a simple device used for percutaneous access. Traditionally, we go into the groin, but for venous access, oftentimes we go behind the knee, we may go into the neck, go radially in the wrist. Anywhere it's used. This is actually kind of a large bore. They do come in French sizes 4 through 11. They come in lengths of 10 through 25. What we have today is a 10 centimeter, and the 25 centimeter, of course, will be used in the event you need additional support further along the vessel. It's a kink-resistant tube device. Notice I said kink-resistant, not kink-proof, so if you bend it, you can kink it. We try not to do that. The inner lumen itself, the inside tube, is rated at 7 French. This particular one has a thin wall design, so the hole is smaller. We're actually making less damage to the surrounding tissue while still allowing large devices to travel through it. It has a rotating side port, so you can actually put this off to either side for use. And that is used for pressure monitoring of the patient. You can hook an art line up to this. Flushing to keep it clean. Here in neurology, we actually keep everything hooked up to heparinized saline all the time to reduce the chance of any air at all becoming embolic. It can be used for drug administration, and of course blood draws for on-site testing during the procedure. The dilator itself, that's used as an introducer, is a stiffened introducer. It has a tapered design. It's longer, and that's for better dissection of the tissue as it's entered into the tissue tract toward the arteriotomy. And finally, we have a crosscut valve at the top. That's actually one of the more important features of a sheath, and that allows near bloodless exchange of catheters and wires. As we're in the procedure and you have your access to the artery, we can exchange catheters and wires without the blood simply spilling out of the arteriotomy. The way this is set up is the kit itself comes with the sheath in place. It comes with our introducer, and it comes with a 35/1000 introducer wire. So you can actually get access with either a traditional 18 gauge cellular needle or a 21 gauge, like a micropuncture set, for less chance of damage to the vessel. You simply increase size up using a cellular technique to the wire to get us where we need to be. So now what we're going to do is we're going to prep our sheath. So we want to make sure we have that and this available, and then we have some sort of heparinized saline available in a syringe. So we make sure all of our parts are available. We take this, we take off our cap, we hook up the saline, flush the side port, cap it back off, lock it to that. We would flush through this tube, make sure that we would push out all the air through here, give it a little tap to make sure to dislodge any that may remain in the bottom here, and then we would lock it toward the sheath. Next, you put in the introducer. That actually fills the entire length of that, thus reducing air once again, and then you flush through this. The sheath is now prepared to be used. You're on your way to safe, efficient vascular access. So let's go over what we learned. The sheath is a simple tube. It's used for safe, minimally invasive access to an artery or vein, and it has features such as a valve, The side port, taper design, smaller profile, and it comes standard in 10 and 25 centimeter lengths. It's been around for about 30 years. Prior to that, the physician simply used direct catheter access, which was actually a mess. Early in my career, I worked with a physician or two that still did that. This is a much better system. Do you feel that you could simply and safely prepare this for use? Any questions? All right. Have safe and happy vascular access. Thank you.